Good evening and welcome to yet another of the Integrated Health and Wellbeing Council's web programs. This time we are focusing on a particular kind of a cancer, which I will leave our distinguished guests to best describe. We are joined today by some very senior and experienced people, and I would like to get out of the way very quickly and just keep guiding the conversations with a few questions here and there. And hopefully, you, the audience on Facebook Live and the other channels, will be able to not only hear from the experience and insight that our guests have, but also be able to put in your questions, which I will direct to them. We have from Kolkata, from the Tata Medical Center, Dr. Maman Chandi. We have from Bangalore, we have Dr. Hari Menon. We have from Noida, Delhi, we have Dr. Ravi Mehrotra. We have from the Tata Memorial Hospital in Mumbai, Dr. Manju Sengar. Between them, I think there's more than a century worth of experience and insight into handling cancers, that too of the particular variety that we're going to be talking about. Sir, ma'am, thank you for your time. When people get confronted with the word cancer, it is almost like there is an impending doom gloom for the individual and for the family. And when people are told that there is a blood cancer, that becomes even more cause of worry because then it's not easily understood. And that's what we're going to talk about, one particular kind. And so may I ask Professor Mamanchandi, if you could kind of start off with, what is it that we're talking about when it comes to the broad range of blood cancers, and within that, lymphomas, and particularly non-Hodgkin's lymphoma that people get confused with or are confronted with? What exactly are we talking about? How does a layperson understand what non-Hodgkin's lymphoma is?
Okay, so basically in our body, we have white cells, and among the white blood cells, we have another type of cell called the lymphocyte. It's a type of white blood cell. The majority of cells in an adult are neutrophils, and these neutrophils are involved with catching any bacteria which enters into our bloodstream or which enters into our body. But that is not what we are going to talk about today. We are going to talk about the lymphocytes. And any tumor which arises from the lymphoid system is called a lymphoma.
Right? So may I hold you there for a second? Just to kind of, I have to translate, and that's my job to kind of probably translate some of this. So for those of you that are listening to us, the blood that circulates in our body has two majority kinds of cells, the red ones, which give us the oxygen carrying capacity in our blood. And then there is a one that kind of allows for the body to fight infections, the white blood cells. The white blood cells are further categorized into different shapes and functions. And that one of them is what Professor Chandi has described as the lymphocytes, and a tumor in that space is what Professor Chandi is describing. Go ahead, sir.
So if you get a proliferation of lymphocytes, which is malignant, and it occurs within the blood, then we call it lymphatic leukemia. Suppose it occurs within any organ in the body, mainly in the lymph glands of the body, then we call it a lymphoma. Now, sometimes a lymphoma which started in the lymph glands can spread into the blood, then it becomes a lymphoma with a leukemic spread. That means it's become like a blood cancer, but it may not be as severe as a blood cancer. So in our body, in every tissue of the body, in the lungs, in the thymus, in the intestine, we have lymphoid cells. That means when they are in the blood, we call them lymphocytes. When they are in the different tissues of our body, we call them lymphoid. And a cancer can arise from any organ in the body of lymphoid cells, and then we would call it a lymphoma, right? Now, lymphomas are of two types, basically. One is a Hodgkin's lymphoma, described by Thomas Hodgkins, and he was the first one who had the idea that lymph glands can enlarge because of something other than infection. So if you go to the Guy's Hospital in London and go to the library there, in the library, they have lymph glands with Thomas Hodgkins himself described, and which are an example of enlarged lymph nodes due to something other than infection. And that is why it is called Hodgkin's lymphoma. And a lady called Dorothy Reed is the first one to describe a type of lymphoid cell called the Hodgkin cell. And that is, today we call it the Reed-Sternberg cell. If that cell is there in the lymphoid tissue, then we call it Hodgkin's lymphoma. Now, for want of a better term, if that cell is not there in a malignant proliferation of lymphocytes, then we call it a non-Hodgkin's lymphoma. It seems like we had no other way to call it other than to say that Hodgkin cells are not there, or Dorothy Reed Sternberg cells are not there, and therefore lymphoid proliferation, which doesn't have those cells, is called a non-Hodgkin's lymphoma.
Thank you, Professor Chandy. I mean, just to kind of help our viewers along, the white blood cells, or the fighting part of our body's immune system in the blood circulation, they can be found in the glands, the lymph, and then you can have them circulating. Proliferation of them in the lungs or in those lymph nodes or in the blood cells are two different presentations. We are thinking only about how they proliferate in the lymph nodes, and this is to be distinguished between the fighting function with infections. And that's something that your primary care physician should be able to rule out. If you have an infection, or if you have got something like TB or something else that is the body is fighting and the lymph nodes are involved, they may pass off with either time or with treatment. And when things don't settle down, you end up with, say, Dr. Hari Menon in his clinic. What do people come to you first, Dr. Menon? When they present to you, what do they look like? What is their complaint like? And what should they be kind of thinking about? Or what should our viewers be thinking about if they need to come to you? You're on mute, sir.
Well, how about now? Can you hear me?
Yes, please go ahead.
Yeah. So yeah. So can I go ahead? Yeah.
Yes, please.
So
Dr. Mehrotra, if you can kind of mute your line, please. Thank you so much. Yeah.
So the commonest presentation that is usually because the patient might be experiencing a swelling, which is the commonest presentation in a lymphoma, and that is the same for a non-Hodgkin's lymphoma too. And also, it depends upon where the swelling might be. Sometimes, if it is located in the abdomen or something, the patient may present with some abdominal discomfort. The other thing that many patients will present, what we call as constitutional symptoms. So they may be presenting with some low-grade fever and unexplained weight loss, a loss of appetite. Sometimes, if they have disease like these lymph nodes in the abdomen, they tend to present with some what we call as postprandial discomfort or a bloating of the abdomen. again, it depends upon where the lymphoma affects, and sometimes they can affect the bone and bone marrow. And if they affect the bone marrow, as Professor Chandy said, it can compromise the functioning of the bone marrow. And in those situations, a patient can present with low hemoglobin, sometimes more rarely low platelet count, or sometimes a patient can even present with recurrent infection, like in some of the low-grade lymphomas, particularly what we call as chronic lymphatic leukemia or small lymphocytic lymphomas, where you are prone to infection. Patients can present with unexplained infection. So the presentations can be extremely variable. But having said that, the one of the commonest presentation is with a swelling anywhere in the body, either in the neck or in the armpit or in the groin region, or for the matter, abdominal distension because of nodes present in the abdomen.
Dr. Menon, thank you so much. So what you're describing is somebody who could come in with a swelling, and it could be any part of their body, or it could be a kind of an unease, which is unexplainable. And so people having tried many things now turn to you or turn to a cancer specialist to say, is this something that I need to worry about, or is this something that needs further investigation? We are joined this evening by Mr. Hemant Gupta from Jaipur. Along with our eminent specialist, we have a patient. गुप्ता जी, आपका क्या प्रेजेंटेशन था? आप डॉक्टर के पास किस लिए गए और आज आपकी क्या स्थिति है?
मैं जुलाई 15 में मेरे नेक में एक नॉट हुआ, गांठ सा हुआ
जी।
मैं डॉक्टर फैमिली डॉक्टर को उनसे बात किया तो उन्होंने गांठ हो गया होगा तो आप एंटीबायोटिक ले लो 5 डेज। 5 डेज मैंने एंटीबायोटिक लिया तो लेकिन उससे कम नहीं हुआ और राइट में वापस एक छोटा नॉट और हो गया। फिर मैं उनके पास गया तो वो बोले मुझे कोई डाउट है, आप एक टेस्ट करा लो, एफएनसी करा लो। नेक्स्ट डे मैंने एफएनसी कराया तो वो मेरे पॉजिटिव आया। फिर मैंने डॉक्टर अडवाणी है बॉम्बे में, उनको कांटेक्ट किया और मैं बॉम्बे नेक्स्ट डे बॉम्बे आ गया
जी।
बायोप्सी हुआ और सारे इन्वेस्टिगेशन हुए तो मेरे सारा एनएचएल बी सेल लो ग्रेड का निकला। तो मेरे कीमो स्टार्ट हुआ, 6 सर्किल मेरा कीमो का हुआ। फिर उसके बाद 2-3-4 महीने मेरा ठीक रहा। फिर अप्रैल मई मेरे 16 से वापस प्रॉब्लम शुरू हुआ। जुलाई से मेरे को उन्होंने आर-चॉप एक कीमो होता है या एक एब्रोटिनिब मेडिसिन है, वो मेरे को वो थोड़ा कॉस्टली था लेकिन उन्होंने मेरे को रेफर किया तो मैं अब तक वही मेडिसिन ले रहा हूँ 2016 से। और मेरा बीच में मेंटेनेंस के लिए मैं टास्क लगवाता हूँ बीच में, तो मेरा ठीक चल रहा है, उससे कंट्रोल है।
गुप्ता जी, आप कह रहे हैं कि 2015 में आपकी डायग्नोसिस हुई क्योंकि आप जो गांठ थे वो डॉक्टर ने 2 बार ट्रीटमेंट कराया, लेकिन उससे जब सुधरने को नहीं आया तो फिर अगला टेस्ट कराया। तो मैं डॉक्टर मंजू सिंह, प्रोफेसर मंजू सिंह से पूछना चाहूंगा। प्रोफेसर सिंह, most of the people who present with something like what Dr. Menon said, I mean, with something that's unexplained, which has not been resolved by the primary care practitioner or the second level of a referral, how complicated does the diagnostic procedure become?
So actually, lymphoma does, as you know, Dr. Chandy and Dr. Menon both have said that lymphoma is present with lymph node enlargement, which is so common. You know, if you go to a primary physician, he or she may be seeing many more patients who present with lymph node enlargement, but not each lymph node enlargement is a lymphoma. In fact, the more common reasons are something which is related to infections or something which is just you had infection at some other place and body is just trying to fight that infection, and that's why your lymph glands become a little bigger than what they are normally. So difficulty comes in when people have taken treatment, especially with steroids outside, because sometimes in the primary care practice it does happen that people receive steroids for these lymph node enlargement. And that's where making a diagnosis when they present to a tertiary center or to a secondary center becomes difficult. Otherwise, as you know, Mr. Gupta has said that he was given antibiotics, which is the perfect way how you would treat somebody who comes with the lymph node enlargement first, because infection is your first diagnosis. Having said that, if any lymph node is not going away or enlarging for more than 3 weeks' time, then in that case, instead of continuing empirical treatment, we suggest that they go ahead and do a lymph node biopsy. Many times people just do a needle test where they just take out fluid, and many times it's very difficult to differentiate lymphoma from an infection on a needle aspirate where you've just taken out some liquid. And as I said, the commonest reason is infection, and in our country, tuberculosis. Many times people continue to receive anti-tubercular treatment for a long period of time. And it does happen that, you know, after 6 or 8 months, when there is no resolution, then they end up getting a biopsy, and then we come to know that it's lymphoma. So just a general dictum for everyone, you know, who's there on the call, that if you have a lymph node which is not responding to the usual treatment being given, and if it's increasing, and if you have, you know, numbers increasing, it's best that we go ahead and take a specialist opinion and go ahead and consider doing a biopsy there.
Professor Sengar, thank you so much. So audience, the rule of thumb should be, one, if you have a swelling, don't sit on it. Do consult your primary care provider, your family physician, or whoever doctor that you can get to. They will treat you, and in most cases, they might appropriately treat you for an infection. But if it's not resolving, you also have the ability to ask your physician, should we be investigating this a little bit more? Because if it was an infection and if the treatment was correctly applied, then things should have resolved. And if it's not, then you are, along with your physician, well within your rights to be thinking and asking for a next level of opinion. Let me talk to Dr. Mehrotra here. And I came to you last because I want to kind of pull back. How many such cases, or what's the incidence of lymphomas, non-Hodgkin's lymphomas in India, that today we kind of are expecting to see? And really speaking, what Professor Sengar said, do we have the requisite infrastructure in place to be diagnosing all of that?
You see, fortunately, Dr. John, the number of cases presenting with non-Hodgkin lymphoma relatively lower in India compared to many countries in the West. For example, if you were to take 100,000, that is 1 lakh individuals, the adjusted age incidence of non-Hodgkin lymphoma will be roughly 2.9 or little less than 3 in males, and half of that in females. That is 1.5 in females and 2.9 in males, which is 1/4 of the incidence that you see in Europe and North America. That is the good news. But unfortunately, the bad news is that many of our individuals presenting with non-Hodgkin lymphoma, by the time they get the biopsy, they get a diagnosis, they are present very late. The tumor may have spread to other parts of the body. So the response is fairly low. In the sense, the 5-year survival, that is normally the time that we consider when we are treating cancers. The 5-year survival is overall roughly about 60%. When you compare to the more developed countries, where it is at least 20% higher. The second point I wanted to make was the average age of the individual with non-Hodgkin lymphoma is roughly 10 years younger in India and a few other developing countries as compared to the West. The problem that one's come across is because they are younger, for example, the average age would be roughly about 50 years. They are in the productive period of their life. They are maybe the main wage earners, and by their chronic illness or by their expenses that are there in the treatment, they lose their earning capacity, which affects not only themselves, but also the rest of the family. The second part of your question, John, was what are the treatment facilities available as far as non-Hodgkin lymphoma are concerned?
Diagnostics, sir.
Okay. Diagnostics, okay. As far as the diagnostic is concerned, as Dr. Senger also mentioned, vast majority of lymph nodes, if it is a node in the neck or in the armpit, which are the two common areas where lymph nodes normally go up or become palpable, the most common diagnosis, 90 to 95%, some infection. It may be a very minor infection which can be cured, or it can be tuberculosis, which is the most common chronic infectious disease even today. And we lose a lot of patients to tuberculosis. So unfortunately, many patients with Hodgkin's or non-Hodgkin lymphoma are initially diagnosed as tuberculosis. There are certain microscopic features which are known as a granuloma are present both in tuberculosis as well as in some lymphomas. So the possibility of misdiagnosis are there. When you talk about further diagnostics, as Mr. Gupta, our individual who has been through the illness, now we have a number of cytopathologists, that is, pathologists or diagnosticians who can do a needle diagnosis, examine it under a microscope, the cells, which is known as cytology, and most centers, anyway, major in India, whether in metros or in the smaller towns, do have facility of a fine needle aspiration cytology. The short form is FNAC, in which we use a very thin needle and we take up the cells, which Mr. Gupta went through. And that quite often is inexpensive and relatively easily available diagnostic technique. If you have a suspicion of lymphoma, you go for a tissue removal, which is known as a biopsy. If it is confirmed on biopsy, then treatment goes in the lines of chemotherapy and radiotherapy where required. If it's a very large tumor or in an area which is vital, you cannot remove it easily, you can go for a major operation as well.
Yeah, so we'll come back to the treatment modalities a little bit later, but I want to kind of now place it into the context of what is happening around us over the last year, 2020. COVID has been right in the context of every which way. People presenting with a small swelling somewhere in the neck, a little bit of feeling unwell, people kind of with a fever, and you don't want to kind of think that it is COVID. Professor Chandy, in your setting in Kolkata or in Bangalore or in Mumbai or in Delhi, each of you, have you seen people reluctant to come early? Are you seeing people come later in the last 1 year as opposed to earlier? Professor Chandy.
I think almost all cancer specialists will tell you that because of COVID, there has been a delay in patients coming to the hospital for treatment. And this generally means that the disease tends to get more advanced. So you might have had a single node in the neck. You say, COVID, I'm scared to go to hospital. You leave it alone, it gets bigger, and then other nodes start popping up. You say, hey, I can't take the risk of COVID, so I'm not going to go to hospital. And then 6 months down the line, you start losing weight, you feel very unwell, and then you say, hey, I better go to hospital. And finally, you land up in hospital. And by then, your disease has become a bit more advanced. So I would say that yes, the pandemic has resulted in delay in onset of cancer treatment, and most cancers, patients tend to delay and come later. So if you look at our own hospital in Calcutta, during the pandemic, in March, April, May, our numbers came down drastically. And now we are having a sort of a rebound. We are seeing 900 patients a day. And therefore, it is because people delayed quite a bit that it would adversely affected the outcome and prognosis. Not so much for lymphomas as it is for, say, a breast cancer or cancers like that, which were curable by surgery if they were detected early. The delay in presentation can harm the patient.
Professor Chandy, thank you so much. I mean, as Dr. Mehrotra pointed out earlier, in India, while people tend to have lymphomas earlier, about a decade earlier, they come to a diagnosis or they come seeking for treatment later in their disease progression. And so therefore, that is a problem by itself. And coupled with the context of COVID, that delay becomes even more. Is that completely hopeless when people delay it even further, Dr. Menon, when it comes to, or is it something that's still salvageable and something that you can work with?
Yeah, both. I would say that it's both adverse and may not be as much as a problem also in the same breath, I would say, as Professor Chandy talked about in terms of when we're dealing with solid tumors over here. Fortunately, we are still able to salvage a good measure of lymphomas even in advanced stage of disease. So when we are talking about the high-grade lymphomas, as we would say, we are still able to salvage close to 45-50% of them even advanced stage disease too. But that doesn't mean that I should not be conveying the message that the patient should come back late. I mean, but the fact remains that they continue to be highly curable malignancies, and it also depends upon the type of lymphomas that we're dealing with. Then we have the other entity which our patient over here was dealing with is the low-grade lymphomas, which invariably at presentation, because of the indolent nature of the disease, they tend to present late, and most of them are in either stage 3 or stage 4 disease at the time of presentation. And we still can give them effective treatment over there. Yes, we do understand that early stage disease has better outcomes, and that is true for lymphomas too. But as compared to other solid tumors, we are able to salvage a great number of patients, even in advanced stage, when they present in the case of lymphomas. So that's what we need to know.
Dr. Menon, thank you so much. I mean, so the audience, I mean, look, if you have a swelling, do not delay. Yes, COVID is a context now. That should not prevent you from seeking the care that you need and that you should be getting. That said, if you can't have gone right in the beginning, go at the first available opportunity, because your clinician can do so much more. Now, each of you, doctors, are working in, let's put it this way, referral centers. And I want to come to Professor Sengar here. What proportion of your non-Hodgkin's lymphomas are first diagnosed in your center? And the answer to that, I have a follow-up for that. What proportion of it? If 100 people turn up and you kind of diagnose 100 people, how many of them were first-time diagnosis at your center?
So, as you rightly pointed out, that we are a referral center, and somebody has raised a suspicion of cancer, and that's a reason why they have come to us. So people who are diagnosed as non-Hodgkin's lymphoma with no prior diagnosis of cancer, and somebody has just suspected that it's a lymphoma just because there are lymph nodes, there are signs and symptoms which are suggestive of lymphoma. So if you're talking of those 100, I guess not more than 20 would fall in that category. Majority would have had biopsy outside, and that biopsy would have reflected a possibility of lymphoma, and that's the reason why they are referred to our center. So 80-20 would be the ratio at a referral center, which would definitely not the case, in people who are in the community and handling these people firsthand.
That's a very encouraging number and a response that I want all of us to understand, that diagnosis is not necessarily restricted to apex centers. You can have a reasonable diagnosis in your district level hospitals or in smaller town hospitals. Any clinician and a pathologist with a reasonable index of suspicion and skills could be able to set you on the way of a proper diagnosis. And so therefore, if we kind of work and network along with our primary and secondary care providers at the district and sub-district levels, we can have an earlier diagnosis. The delay that we have talked about is essentially a delay of both identifying who needs a diagnostic test and then setting them on the pathway to a therapeutic continuum. Once they are diagnosed, how difficult is it for people to start off on a treatment? Diagnosis seems not to be the problem. Professor Senga, and then I'll come to Dr. Mehrotra.
Correct. So I completely agree with your point saying that diagnosis or suspecting lymphoma is something which is not difficult. Having said that, given the nuances further for subtyping, so lymphoma is a broad family. We need to identify what's the exact subtype of lymphoma. As Professor Chandy mentioned that it's Hodgkins, non-Hodgkins, and within non-Hodgkins you have several subtypes. As Hari was trying to allude to, that there is something what we call as low-grade lymphoma. There is something, there is a category of high-grade lymphoma. So that is something which requires a bit of specialization. So you're right, suspecting and the initial diagnosis is not difficult, but yes, sometimes you need that specialist approach as well as pathologist to make the accurate subtyping, because that's important as far as the treatment is concerned. Coming on to the treatment for majority of lymphomas, once you have appropriately diagnosed the subtype on the pathology and you have looked at the person who's carrying the lymphoma in terms of host, that he's fit for a particular therapy, and you have staged the lymphoma appropriately by doing various scans as the case may be, as well as the bone marrow if needed. Once you have done that, the treatment protocols are quite standardized. And for majority of lymphoma, the treatment is done with the certain regimens which need to be delivered in some particular dose at desired frequency. So I don't see a complication in majority of the lymphomas, especially if we are talking in terms of younger people who do not have several other illnesses which interfere with the delivery of chemotherapy. The problem comes in when you have lymphoma, which is little rapidly progressive, where you have a host who's not really well preserved because he or she may be having other illnesses, which may increase the risk of complications. That's where the problem comes in, and you need a multi-specialist approach. You need the oncologist who can handle the complications. So, but otherwise, for majority of lymphomas, the treatment can be delivered, but we need to make sure that it is done as per the protocol, because some of these lymphomas have one chance for cure, and we need to maintain that we deliver the chemotherapy in the desired doses at desired interval.
Thank you, Professor Senga. गुप्ता साहब, आपसे मैं पूछना चाहूंगा, आपका म्यूट पे है, आपका डायग्नोसिस जयपुर में हुआ।
हाँ जी।
आप बंबई गए ट्रीटमेंट के लिए, क्यों?
जयपुर में प्रॉपर मेरे को रेस्पॉन्स ऐसा लगा नहीं। 2-3 डॉक्टरों से मैं मिला, तो डॉक्टर ने डॉक्टर अडवाणी को कांटेक्ट किया। डॉक्टर अडवाणी नेक्स्ट डे मैं चला गया, मैंने वेट नहीं किया जयपुर में। फिर वहां जाके मेरा तुरंत ट्रीटमेंट शुरू हो गया। बायोप्सी हुआ, पेट स्कैन हुआ, सारा डायग्नोस हो गया, फिर कीमोथेरेपी मेरा स्टार्ट हो गया। विदिन 7 days मेरा ट्रीटमेंट स्टार्ट हो गया था मेरा।
Right. Thank you, Gupta ji, because that sets me up for the question for Dr. Mehrotra. I know that you are leading up with the Cancer Research Consortium. That's clearly not restricted to just the major metros. It kind of goes down hopefully into the district levels and across the country. Is there a reason, or should there be any reasons for the experiences of Mr. Gupta who needs to move from a state capital to another higher center, or is it something that can be now more confidently managed at different state and district levels?
Yes, Dr. John, I fully agree with you. That is, rather than moving the patient to a far off tertiary center, it would be ideal if we can move the center to the patient. Unfortunately, as far as the state of Rajasthan, which is where Mr. Gupta comes from, there is one regional cancer center in Jaipur. But as you are well aware, there are wide variations and discrepancies in the kind of facilities available between state to state. For example, in Bombay or in Delhi, there are at least 10, maybe more cancer centers which can easily diagnose and treat non-Hodgkin lymphoma without any problem. When you go into the relative hinterland, Jaipur is definitely not hinterland, it's a state capital of one of our larger states. Unfortunately, there is a certain amount of discrepancy as far as facilities are concerned. Number two, it is the individual's choice and the right of the individual treating doctor where he or she feels comfortable in sending the patient or certain investigations, which can, I think, easily be done in most of the major metros and treatment started. Fortunately, Mr. Gupta could afford traveling the very next day by flight or by train to Bombay, and he could, as Dr. Sengar and her colleagues know very well, there is a long waiting list of people waiting to see the specialist in Bombay. It is a private setup or a government setup. He was lucky to have got through to his physician, but he may have had to wait for a month altogether, as you might remember seeing that iconic picture of when COVID started under the metro overbridge across Tata and Parel. There were huge number of families and people who had no hotel. There was a lockdown, they could not travel, and people were helping them with food. So many other problems do arise. So what I am hopeful of, that gradually, and I hope sooner rather than later, these facilities will be available at least in the capital and the major cities of the country. It is happening already. Now, many people are quite comfortable in getting investigated and treatment in their city of choices. And there have been many initiatives, not only from the government, but also the private setup. From the Tata Trust, for example, they have taken over the cancer care of the Northeast, where Northeast has the maximum number of cases, if you take per capita in the country, and they have opened 5 cancer hospitals in Assam. And I think they're going further as well, which is again a major problem. You can imagine a person from Nagaland or Mizoram flying all the way to Bombay or to Delhi. It's not an easy job, and it is expensive. Sikkim, for example, is one of the most developed states in the Northeast. They have just opened their cancer center very recently. So everybody, of course, they have a very small number, but the state government of Sikkim used to pay them to come to Delhi or Bangalore or Bombay. But now gradually that is also changing. So I am reasonably optimistic that not only research, but also patient care is being decentralized. In addition to the private setup, of course, you know very well, all the major cancer hospital chains, so to say, are there in every major city. But as the affordability increases, some of the government programs, including the Ayushman Bharat, that is also making a change, although it is early days, of at least the bottom 30% of the pyramid as far as paying capacity is concerned is governed, and up to a figure of 5 lakh rupees is covered, paid for by the Ayushman. That is, I know it's early, I know there are problems, but things are changing. So in the government setup, in the private setup, and various NGOs and civil society, things are changing. But India is a country of 1.3 billion people, 3 times the size of US in terms of size and probably the complication that we have. It is not a thing which will happen in a hurry, but I'm still optimistic things are changing.
Professor Mehta, thank you
I
so
wish
much.
I could.
No, we could, but we are more 1.4 billion, not 1.3. But here's a question. I think what I'm getting a sense, and what I think our audience is getting a sense, is this: if you get to a reasonably competent primary care provider, you are directed very well. If you get a good diagnostic procedure done earlier, then you have got something much better off than coming in later. One of the experiences over the last 9 to 10 months has been this use of new technology, where Dr. Menon, sitting in his hospital, could be able to zoom into a clinic somewhere else, or Professor Chandy sitting from Tata Hospital, or Dr. Sangha sitting from Tata Hospitals in Bombay or Calcutta, being able to zoom in. Is it a possibility today that we could see clones of you, in the absence of physical replicas of each of you, in every 750 districts of us in this country? It's a large country. Can we begin to leverage that allows for better quality of a treatment supervision, so that people don't necessarily have to come to you, but you could be virtually available, partnering with those that are there on the front lines? And I'll start with Professor Chandy.
I want to sort of interject a small word of caution. Okay.
Yes, sir.
Lymphomas, particularly non-Hodgkin's lymphomas, are very complex disorders, and it can range from an aggressive lymphoma, which, if you are not treated quickly, you can end up with renal failure, with breathlessness, with tamponade, with whatnot. So the spectrum is not that all lymphomas are one swelling in the neck and you're well. Some of them are very aggressive diseases. They are almost as bad as having a blood cancer, right? The second is, in that type of a cancer, if you delay diagnosis, it can be costly. Hari said that yes, we can salvage the majority. But I have had patients, 20-year-old, goes to the doctor with a swelling inside his chest, tuberculosis, and he's given anti-TB treatment for 6 months. And by the time he comes to you, he's breathless, he's got a superior intestinal obstruction, he's got a pleural effusion, he's got a pericardial effusion, and he is desperately sick, right? And the second thing, that diagnosis of lymphomas is not easy. There are a lot of nuances to diagnosing a lymphoma, and to be sure that you are dealing with this type of lymphoma. And today, some of our pathologists will not stick their neck out till they have done a battery of monoclonal antibodies to say that this is a Burkitt lymphoma, right? They're not going to stick their neck out. They want the sophistication of a precise diagnosis. And today we may even require molecular tests. We may even require a FISH test, fluorescence in situ hybridization. So I do not want the audience to go away thinking that all lymphomas, non-Hodgkin's lymphomas, are simple diseases which can be managed at a district hospital. I think that some patients, and particularly with regard to the diagnosis, right? So they would require precision in correct diagnosis, because the treatment is different, right? So I would say, yes, there will be a time, but my personal opinion is they should come to a good center for their primary diagnosis, and then the chemotherapy protocol can be decided on. And particularly in indolent lymphomas, they don't need to come and see us again maybe for 6 months or a year. and their local team can manage them, give them simple chemotherapy. But if it's a young person with high-grade aggressive lymphoma, I think they need treatment in the tertiary center.
Dr. Menon.
Yeah, so I cannot agree with more on this because I always tell my patients that the treatment of the patient is not the major hurdle. It's the diagnosis of the patient that's the challenge. And because that has a lot of bearing on the kind of treatment that we implement. And as Manju had said before, that many a time, the first time is your only chance to get rid of the disease, and you may not get a second chance. And that is particularly true about conditions such as Burkitt's lymphoma, or for that matter, like the mediastinal mass that is present, like a primary mediastinal B-cell lymphoma, so many things. So it becomes critical for us to make that specific diagnosis, prognosticate the patient, implement the right treatment so that he doesn't have to come back to you a second time, or decrease the chances of having to come back to you. So I would say that we must really sort of build up the pathology backup of every institution, and at least there should be one good pathology set up in every state or any of the metros, where you can actually send a person, send your specimen for a lymphoma diagnosis, and after which perhaps these teleconsults, which has actually come into vogue more so in the last 10 months or so, may become practical. So I always say that I am still not completely comfortable with these teleconsults, because there are a lot of things that you would like to look into, and you're just listening or seeing what has been provided to you. And nothing replaces actually seeing the patient and also looking at the pathology and establishing diagnosis. But I know it's a tall order, but that is something that one has to sort of try to move towards. But again, the treatment can be meted out to the patient in any center that is capable of delivering chemotherapy and managing the complications.
Professor Chandy, Dr. Menon, thank you so much, because when I started off on this with Professor Singer on the diagnostic part of it, one of the things that I personally believe, and I think it's a dictum for all of us, is your treatment is only as good as the quality of your diagnosis. If you don't have a fairly precise diagnosis, or a reasonable one at that, you're going to kind of be beating around the bush for a while, till you kind of either have spoiled things or you've kind of arrived at what you need to do. And so therefore, is there a lesson now for going beyond looking at the lymph nodes and getting into the precision of the diagnostic procedure? And I know that, Dr. Manju, you kind of spoke about this earlier, that sometimes you get too thin a sample and you don't know what to kind of make of it. You need to do a little bit better than that. What is it that, like Dr. Menon said a little bit earlier, how do you improve the capability of diagnostics? Because if you've got reasonable diagnostics, and with the alarm bell or the warning bell that Professor Chandy has kind of rung, that is something that you might miss out on, what would you like to see?
So as far as diagnosis is concerned, I think one is definitely the experienced pathologist, the person who's been looking at lymphomas. That's the most important thing here, because you can run a battery of tests. If you don't have that experience, sometimes even the interpretation is an issue. So first is the experience of the pathologist in diagnosis of lymphomas. Second, then you're just not looking at the microscope and seeing these stained slides. It has to be complemented with the good panel of what we call as markers. We call that as immunohistochemistry. And in some of the cases, you may need to go beyond that. You may just, you cannot just make the diagnosis on just by looking the slide under the microscope, by doing immunohistochemistry. You may need certain special tests, what we call as FISH test and the other molecular tests, to say that, whatever you're seeing is a clonal disease or not. So there are additional tests which may be needed depending on the initial appearance of the slide under the microscope as well as the immunohistochemistry. So that these are some of the additional tests which may not be available everywhere. And in that case, you may need to go to those specific centers where these facilities are available.
One of the things that my personal learning from the work that I've been doing on tuberculosis has been simple. We may not find enough radiologists in every place to look at a chest X-ray, but we can make images move, and we can make images be amenable to examination in the bulk elsewhere. Is that even a likelihood or a possibility for the better diagnosis of lymphomas, especially in places where you may not have experienced pathologists? And I open this up to all of you. I mean, what do you think the role of image transmission is in enabling better diagnosis, assuming that somebody is able to get good tissue samples and process them?
So as you rightly said, the basic assumption there is that you need to have good biopsy, which has been taken, a good tissue processing, which has been done, and the appropriate controls have been, in place for interpreting the results. So COVID in our own hospital, and I'll talk the experience from our own hospital, has, pushed digital pathology a little bit, because many of the people, because we needed to have social distancing, we had to cut down even our staff attendance. And I'm not sure if you've ever visited Tata Hospital. We are perennially in terms of overcrowded, both in terms of staff, space as well as for patients. So we did start a lot of digital pathology there. So I guess going forward, if we want to take it and if we want to decentralize the things, that patient need not move, only the material moves or the images move. In that case, digital pathology can be helpful, because this did work during the COVID time when people did not need to come to the hospital for reporting. Yeah.
So this is to kind of Dr. Mehrotra and then to Professor Chandy. I mean, we are in the throes of both the need to scale up our services and also things that are contextually changing. Do these two imperatives enable us today to be creative about how we expand our offering of both early screening, diagnostic, and therapeutic services for those with non-Hodgkin's lymphoma?
Dr. John, what I would like to talk about, and this follows on from what Dr. Manju Tenkar has been mentioning. Although there are a lot of advances in teleradiology, that is X-ray movements or CT or PET images going up and down the country or across the borders as well. You can have a hub and a spoke model. So the hub can actually have an expert who can look at images. Unfortunately, those same advances have not happened so far in the area of pathology, specifically, and immunology. So far, we've had static images going up and down for people to give an opinion. And there are three reasons for it. Number one reason is that pathology images, because we have a whole slide imaging. The entire slide is, the image is grabbed, and that is a huge file. Although with improving internet speeds and capacity to move the information, that is changing now. Secondly, the pathologists have not had a need to actually move from one place to another as far as the images are concerned. So they are not comfortable with it. Although again, things are changing, especially with the COVID. We've been forced, our hand had been forced to look at it. And thirdly, there's an implication of ethical and responsibility. If I have not seen the slide, I'm not comfortable doing it, my signature is going to be the final one. In spite of the fact that I have the ancillary tests like immunohistochemistry, I have facility of a FISH assay in which chromosomal or molecular abnormalities are there, I don't have the same level of comfort with many radiologists have. So what I'm hoping for is the COVID situation is not going to go away. I mean, it may decrease, I hope it decreases, it's not going to go away. This could actually be a trigger of a change in mindset. Now with technology, the fact that we are having this webinar, even 2 years ago would have been next to impossible. And getting people to watch a webinar is so difficult. let alone participate, especially you are eminent experts from all over the country, if not overseas quite often. So I think things are changing, but we are not quite there. And way I can see, especially looking at digital health and looking at personalized medicine, which I'm sure you're going to go in later, it will take some time. It is not going to happen overnight. Thank you.
Dr. Menon, and then I'll turn to Professor Jandy for his last thoughts. You're on mute, sir.
Sorry. So it is something that we have to explore more in the future and fine-tune in terms of expanding the expertise and the finesse in the diagnosis of lymphomas, because we all appreciate today that lymphoma is not one entity, and the diagnosis and the precise diagnosis, which go a long way to not only increase the requirement for treatment and many a time also decrease the requirement for treatment, adequate staging measures, looking at specific radiological features which can help us understand the extent of the disease and also understand the responses to disease in the future, and also where we need to probably escalate therapy if the responses are not achieving the responses that we desire. So we have to move towards that. We have to expand the expertise of the lymphoma pathologists to a wider population, because as Manju said, it is something that cannot happen overnight. Only people who have been looking at lymphoma pathology repeatedly develop that, we can say, the sixth sense to actually diagnosis with a lot of precision, and so that we can go ahead. And there needs to be a lot of training program also for this, because lymphomas are not something that are going to decrease by any measures. It is only going to be there as it is, or maybe even increase, because we know that lymphomas are a disease of the aging population too. So we, as our life expectancy increases, we are going to encounter more of cancers and more of lymphomas too. So it is going to be an issue which we need to deal with. Yes.
Professor Chandy.
So I just want to say that despite the movement into the digital technology era, even today, I would like to see the patient in front of me. I would like to listen to his history. I would like to put my hands on his neck, on his abdomen, and feel what is there, and then go to all this high funda imaging and all the rest of it. So I don't think there will ever come a time where digital technology will take away from what it is, because we're not dealing with mice or cattle, we're dealing with human beings. And therefore, the fact that we can actually talk to them, interact with them, understand how they feel is I think, never going to go away. And when it goes away, then medicine would have lost its art. Having said that, I want to tell you that last week we had a patient with a tumor in his duodenum. And 3 of our pathologists said this is an adenoma with dysplasia. And 1 pathologist said, no, it's an invasive carcinoma. Today we can digitize the slide, which means that it's like actually sending the slide across the world. The pathologist there can move down the digital slide, move up and down, change the magnification, look at it any which way. So we sent it to Yale when we were going to sleep. And by morning when we came back, we had a diagnosis. He stuck his neck out and said, it is this. So I agree with you. But the starting point of digital technology is a properly cut section. If it's not thin enough, if the node hasn't been bisected before it went into formalin, junk in is junk out. So you have to do the basics. You have to have proper staining, proper cover slipping, proper cutting of the section. All of that becomes important. Having a digital slide with junk on the slide doesn't help you at all. So I think, yes, it's going to make our life a whole lot easier. It's going to allow us to cross the globe in seconds and get an opinion from anywhere in the world. And the technology is amazing. If you see a digital slide, which we use for teaching pathologists, it's like giving them a slide in their hands and a microscope. It's just so good. So I agree, yes, our world is changing for the better, and these technologies are going to impact the way we practice.
Professor Chandy, thank you so much. Dr. Menon, Dr. Manju Sengar, Dr. Ravi Mehrotra, thank you so much for your time. Overall, above all, Mr. Gupta, thank you so much for both being present and sharing of your story. As I wrap up, this has been a very immensely enriching experience for me to hear from each of the experts here, as I hope it has been for you in the audience. The experience that Mr. Gupta had is probably exceptional, as pointed out by Dr. Mehrotra, that he was able to get an appointment, be able to get it get his treatment started off in time in Bombay, and today, 6 years down the line, he is here sitting with us as an encouragement that a diagnosis of Hodgkin's lymphoma need not necessarily be doom and gloom, that things can be managed on. And so therefore, for your presence, Gupta ji, bahut dhanyawad. But here's the challenge and the larger points that I want to draw out for us as an audience and for those of us that are thinking more policy-oriented wise. We need to deepen our capabilities of picking up people early on. Clinicians with high indices of suspicion should be able to triage people quicker into proper diagnostic facilities. And that does mean a level of expertise and a democratization of that expertise far more than what is available today. If there are 750 districts in this country, less than 200 possibly have got the capabilities of doing a proper specimen mounting to be able to even get a digital image. That is not acceptable. What is also reliably true is that India will continue to grow older. Every year, we will see roughly between 15 and 18 million people become 60 and over, which means the statistics that Dr. Mehrotra pointed out, that we probably see only a fourth of lymphoma as compared to the Western world, might change as we get to being older. And if that be the case, then the need for more people who are capable of doing a good diagnosis and then supervising a treatment for good outcomes like Mr. Hemant Gupta here is going to become even more important. Treatment for cancers in general and non-Hodgkin's lymphomas specifically cannot be, should not be restricted to big centers like the ones that are represented on the screen, like in Cytocare in Bangalore or in Tata's in Bombay or Calcutta or in the center here in Delhi. It has to be more widely available. It's going to be a push and a pull. A push to deliver the services from the professional side, from the policy side, from the government side, and a pull from everyone who needs to get a reasonable diagnosis and assurance of care, supported by schemes or facilities that prevent people from being impoverished, because that's the other side effect. You do get a good diagnosis, you do get a decent amount of care, you end up becoming significantly impoverished simply because you've spent out of pocket, and that cannot be a good outcome either. Struggling with that will be a larger conversation. But for this moment, I want to thank each one of you, Professor Chandip, Dr. Menon, Dr. Mehrotra, Professor Sengar, Mr. Gupta, for having shared your hour and your valuable expertise and insights into it. Come early and be in partnership with your care provider. That is what is going to make sure that you have a better outcome. Thank you so much. And I want to thank all of you who's joined us on the audience for being part of this conversation. Have a good evening, please.